This scar, if I'm assessing, you know, it's probably normal. She said like this was a pretty superficial. So when we're feeling this one, all right, this would not actually assess if there's anything wrong, but we're going to pretend. Okay, now it's due to just normal anatomy. It has ease is that way. We can see how much easier it goes that way, and bind is that way. So it does not want to go this way nearly as much as it wants to go that way. So we're going to work off that principle that that's the direction of bind. Now we're going to go up and down, a bit more that way, a bit more that way. So direction of bind is superior, and call it lateral. And if I were doing myofascial release, then that just turns into take it to bind, take it to bind, and hold into your board. And I mean, I don't want to hold this long enough for demonstration purposes, but outright you hold that, and I could lengthen the space, hold this further. The more I can make that scar change shape, the better. You know, mobilize. Like anything, a little bit of friction to warm the area up. We don't have any symptoms specific to this spot, so I'm not going to just put her through deep transverse friction just to show off. That's not very friendly, right? All right, so we have a smaller piece of tape. I'm just going to go ahead and tape right over top of that scar. Anchor. Now I'm going to maybe, with a little bit of intention, nudge this. This would be maybe why I pick going in that direction as opposed to superior to inferior, distal to proximal to distal. I'm going to go distal to proximal. Kind of nudge everything up, and then try to hold down there. Okay. Now, most of the tension felt like it was here at the end. See how that middle part was a bit better? Now, for whatever reason, me putting that tape on, it's moving a little bit easier here in the center, this way, and not as much that way. The ends moving that way, less that way. It's probably visually hard for you to get a gauge on, but that's what I feel. It's like now, ease, bind, ease and ease, sorry. Yeah, ease, ease, and ease. So if I'm gonna do this little lattice option, I'm gonna do a little X, and then we're gonna do some side to sides. So we're gonna do one here, a little anchor, nudge the tissue in the direction of bind, and I would be fine with there being more tape that in that direction, because my assumption is it's going to pull towards center, meaning that area pulled more that way. Okay. It's going to look like the weirdest stitching anybody's ever done. Okay, another little one. Cross. Oh, the anchor is tiny, so. Okay, nudge the tissue and bind. Tack down. Okay. Now, the ends of the scar need to be tugged in a direction. So then anchor across this way. And pull everything down that way. And last one. And I mean, you could do fewer or you could do more, whatever, right? But now we have that scar and the surrounding superficial fascia pulled in varieties of directions, and just based on your assessment skills and your intuition, just try to find that ease and bind element and then tape things in the direction of bind. And then that gives you a clearer argument as to like where you put your first anchor down, which direction to lengthen the tape, and then these other parts is just kind of like how you could make something up in real time.
So when you put it on, so the first bind was this way.
Yep.
So and then once you put that on, that's how you establish where the second one went?
Yeah, it changed on me once I put the tape on. I was like, oh, I reassessed. My first point of bind that I felt with this was this way and that way.
Right.
And so then once I put the tape on, pulling it this way, suddenly it had more freedom in the middle, but not on the ends.
Mm-hmm.
So then it felt like it was bind that way in the middle of it, and bind this way on the ends of it.
You'd always start on top of the scar with the tape.
Sometimes it's just an easier option for you because you know it gives you a nice approximation of you don't even necessarily need that one. You know, you could do a bunch of little ones in a crazy zigzag pattern, like keep on taping things and bind, like this part of the scar, tape that and bind. Find the next portion of the scar, okay, tape that and bind. Oh, this part of the scar wants to move that way, okay, tape that one and bind. You could,
Yeah, like a large appendix scar, you might want to do like half of it one way, half the other way.
Possibly,
That whole thing,
yeah.
How it,
but you could argue the scar always needs lifting.
okay.
So the scar, and that's one argument with doing it that way, is you could just, if you just cover the whole thing, you know, you at least kind of have a general lift up and away, decompressing like that. And then, just as you saw, once I apply that first one, you may start getting a different assessment as you go. So, yeah, either or is, again, it's going to turn into me going, there's not really a wrong way. But this is one that it's like pretty no nonsense, you can't go wrong. Worst case scenario, you have difficulty assessing this. Put the tape right over the scar and do one and the other. Back and forth. Yep, just like the picture. And then you know some of them are going to be taping at ease, some of them are taping it in bind. You won't be able to mess up even if you tried. And that's, but here's just an example of being a little bit more precise. Wow.